Welcome, everyone. Great to see the turnout. So unfortunately, today, one of our speakers had to cancel. So we'll have one talk still today of Samuel Petragallo. And this meaning that we have a lot more room for discussions afterwards. So please also feel welcome to chip in with questions on the chat and or to raise your hand and take the floor. Samuel is an health information system specialist at WHO, and today he'll be presenting HERAMS, and the title of his talk is Modeling Populations Accessibility to Essential Health Services. Samuel, the floor is yours. You should be able to share your screen, or I should probably be the one sharing the screen, so let me just...
Oh, no, Samuel will do it.
Oh, right, okay, go ahead, Samuel.
All right, thanks a lot. Thanks a lot for the introduction. Can you see my screen? Yes?
Yes, we can see it.
Yeah. Shift that.
Yeah.
All right, thanks. So yeah, I'm Samuel Petragallo. I'm with WHO in HQ, and I'm basically leading this initiative called HERAMS. There's a few more people in the call, hopefully. I've not seen everyone, but I think there should be also Caroline Führer and Raphaël Bréchard, who are working with me on this, as well as a few colleagues from the University of Geneva with whom we have a partnership, Nicolas Rey, Pablo Timoner, and Fleur Yering. So the HERAMS initiative, basically the vision that we've set for the initiative is that core information on essential health resources and services should be readily available, first and foremost at the country level to decision makers, but also generated in a way that allows comparison and hence use at the regional and the global levels. The mission we've set for the initiative is to support countries with the standardization and continuous collection, analysis, and dissemination of that information. And to do so over the years, because that work has basically started about 15 or 16 years ago now, we've developed a comprehensive package of services that include norms and standards, a platform to support the implementation of the process at the country level, of which you have the URL here, country support services, analytics and reporting, modeling and operational research, as well as partnerships. The way HERAMS work, or the core principles, if you like, that make it different than some of the other tools that we've been using over the years and that may look similar, are the following. First of all, we're attempting at being exhaustive, and we really want to cover all of the service providers and all of what we call service delivery units, meaning largely health facilities, but also anything else that's used to bring services to the population, mobile teams, mobile clinics, or even community health workers. The approach aims to be dynamic in that it should be able to capture the situation as it evolves. So it's really a monitoring tool. So allowing basically dynamic data capture, but also the process itself is meant to be dynamic and can be scaled up and down depending on the needs and the constraints, basically starting sometimes in affected district and then being expanded further to the other areas of the countries, or even in some instances working with specific partners and then expanding to the rest of the service providers. It's in essence a collaborative process. By no means WHO has the capacity to undertake such an exercise. And the idea here is really that all service providers should be empowered and given the responsibility to share information on the services they're providing to the rest of the community. And so HERAMS is really a process through which we're trying to facilitate that collaboration and also bring accountability. It builds on standards that exist. So we reuse obviously the existing standards, but we also aim to produce a number of standards out of this process around the services and service definitions that we're using. But also an important piece is the generation of what's called the master facility list, which is the list of all of the points of service delivery in any given context. We've been focusing on data that we think is actionable and really only variables that can directly inform the response. And we're also trying to make sure that partners involved in the process, and hence those that are delivering services in any given context, have a guaranteed access to the entire data so that they can use it for planning purposes, response, and so on. Finally, and because we're developing that process through the service providers themselves, and because this is sort of also reinforced with the verification and validation, we're really attempting at generating a picture that is recognized as an authoritative picture of the situation. The data is structured along 6 pillars. The first one, health service delivery unit description, is the master facility list, essentially describing the modality through which the services are being delivered. The second one is looking at the operational status and accessibility of those health service delivery units, looking at things like damage on buildings or equipment, overall functionality or accessibility. In all cases where issues may be recorded, whether in terms of damage, functionality, or accessibility, we, through HIRAMS, look systematically at what the causes are that are creating these problems. And you see a number of examples on the right here of the kind of analytics that we can generate from this data. Then the next 3 blocks are management and support that give us an understanding of who is actually in charge of those facilities and who do the services rely upon. That's been in some instances a very important piece of information. For example, when partners that play a prominent role in any given response decide to pull out of the response for any given reason, that allows us to anticipate on some of the gaps that this may generate and hopefully coordinate with other partners to fill those gaps. Basic amenities, the usual wash, power, and communication, as well as health information systems, looking through those systems that the facilities are reporting through or not. The last block, one of the most important ones probably, is the service availability component. So it looks at a broad range of services across 5 health domains: general, clinical, and trauma care, child health and nutrition, communicable diseases, sexual and reproductive health, NCDs, and mental health. And again, same as for the other blocks, whenever issues are detected in terms of lack of the availability of those services, then a set of systematic questions is run to try and get us understand what the barriers may be that impede delivering the services. I've mentioned this is a monitoring system, so the whole process is built so that service providers and data providers then can update their information regularly. And that, of course, means that any piece of information we're capturing and any indicator, any analysis we're doing can then be looked at over time. So the example you have on the right here is looking at the evolution of service availability in Yemen across those different health domains that we just mentioned. We've recently added, or if you like, extended some of the analytics that we do with this data through accessibility modeling and the partnership we've been setting with the JO Health Group of the University of Geneva. So beyond describing the availability of services, the attempt here is really to start looking at the level of access that communities have to those services in terms of travel time to the health facilities, zonal coverage, referral time, or even geographic coverage. And in all of those cases, the kinds of analysis that we're producing and aiming to produce more systematically are really aimed at better understanding how we could allocate resources as efficiently as possible. Which are the areas where we should be building new health facilities? Which are the facilities we should be reinforcing first? Where do we need to deploy mobile clinics, and so on and so forth, with always in mind or in view of increasing our coverage as much as possible. There's additional data that is needed on top of HIRAMS to run that modeling, obviously. Data related to the geography of the area, elevation, land cover, barriers to movement like water bodies and road networks. And then there's the component that HIRAMS may bring in terms of health service availability. to which we still need to add the health-seeking behaviors. How are people actually accessing the services? So we work with the colleagues from the GeoHealth groups at the University of Geneva in understanding how we could basically feed those models with the HIRAMS data, the kinds of standards we've developed with HIRAMS. How can those be reused as efficiently as possible in terms of the modeling? And there's a small descriptive here on the right, which is the framework that we've developed to support this work. There's a quick example here of Mali, where we are monitoring over 2,600 mostly facilities, HSDUs, over 2,700 community health workers as well, through a network of 172 contributors. And there's two examples of analysis here on the bottom. So on the left is what we've been doing historically. So it's looking at the percentage of HSDUs that are providing basic malaria services, for example, or the number of those HSDUs providing basic malaria services against the population, which is the small table you're seeing here. And we're basically comparing the availability of that service through those two indicators. On the right side, the geospatial modeling is looking at the same issue, but from the geographical access angle. And there's two scenarios that are depicted here. The first one is looking at a motorized scenario, whereby populations can move through motorized means, and that gives an accessibility of above 95%, meaning 95% of the population is able to access basic malaria services. Together with a scenario where we're looking at a walking scenario, basically no motorized displacement, mostly walking, and in which case the accessibility drops to 44%. So looking at the same problem, but in a way, in a much more refined way, and also a way that helps us locate and estimate, helps us understand really where those populations are that can't access, how many are there, and so on. As I mentioned, part of the service package that we're developing to support countries that want to implement HIRAMS is the platform. It's a very important aspect of the initiative, because obviously implementing such a process at the country level is really challenging. There are on average dozens, if not hundreds of data contributors, sometimes that all need to be able to contribute asynchronously to the system. So the very first objective of the platform was to make that process easy, basically, and ease everything related to data collection, but also the maintenance of that data over time. Very quickly, we've worked also on trying to bring services back to whoever onboarded the process in terms of reporting. So there's online dashboarding with the possibility of exporting PDF reports and so on. A very important aspect for us was also to use that as a means of increasing transparency and accountability on the process. So it is clear through the platform who are the individuals that are assigned roles and responsibilities with regards to this data. And that allows us, or will allow us in the longer run, we hope, really reinforce the accountability in terms of the quality of the data that is shared through this process. And same, as I was mentioning earlier, we're also using the platform to ensure that any data contributor can access the entirety of the analysis for the project that they are contributing to, as a means of increasing access to the data. We're also using this platform, which is a central service. So it's a unique platform that has been developed at the central level and is provided as a service to the countries to give visibility to these processes, so that whoever is working in a given country understands whether HIRAMS has been implemented, how lively the process is, and can potentially reach out to the coordinators of that process at the country level to request additional information, access to dashboards if those are not already accessible publicly, and so on. And the last aspect, obviously, of the platform is that it's been fundamental for us in terms of deployment and making those deployments easy. It's huge economies of scale. There's investments made on a single platform that has now been implemented in over 25 countries, 26, I think, to date. So where we're today, as I was mentioning briefly, we've been working on this for the past 16 years. It's been a long process and a long evolution. A few years back, in 2019, we ran an external evaluation in 6 countries, look at the relevance, effectiveness, and so on of the process. And we got some fairly positive feedback, I would say, in terms of how much this has been supporting decision-making, especially in emergencies, and how this has been a driver for collaboration and transparency. But we've also had some interesting results in that it's actually been found to be relevant beyond the emergencies themselves. Or say first, in all of the phases of the emergencies, but also all the way through recovery and in some cases development context. And one of the last points, which I also just mentioned now with the platform, is the effectiveness with which this has been deployed to date. That was highlighted through this evaluation. So HIRAMS is now active in 25 countries through 26 projects, and there's more than 66,000 HSDUs reporting data and a network of about 3,200 data contributors. I think in the past years, we were recently looking at the numbers, we've been training another 1,700 data contributors. So the actual implementation at the country level is really accelerating now. I'll finish with the next steps and then hopefully we can move to the discussion. So what we're hoping to do in the coming months, what we've been working on already, but we're sort of still working on, is essentially reinforcing that service package further and also increasing our support capacity to countries. And that's across all of the levels of WHO as an organization, but also hopefully through partnerships with other organizations. We're also looking at extending the service package to new services, and the geospatial modeling in particular is a work that we've initiated about a year ago only now, and part of those extensions that we want to build and further reinforce in the future. An important point that came out of the external evaluation we really needed to work on was to improve and increase data uptake by decision makers. So I think we've done a lot of efforts in the first years of this initiative in making data collection possible, basically having all of the tools and processes in place that would allow us systematically collect that information. Sorry. And we've now reached a stage where we're really sort of shifting our attention to transforming that information and making it available so that its uptake is actually higher by decision makers. Part of this is the modeling work we just mentioned, and we probably can discuss later. But it's also the operational research work that we're initiating. And we're establishing also a team dedicated to analytics that Caroline here will be leading. And the final point is trying to establish partnerships around this work. This kind of data sets and the analysis that we're developing are obviously of interest to a lot of entities way beyond WHO. And so the idea is to start looking through with other agencies that may be interested, whether we could start thinking of a joint service around HIRAMS that could be given to countries, basically. And I'll stop here, maybe for the discussion or questions, obviously, if there are. Thank you.
Yeah, many thanks, Samuel. That was great and a good overview of all the different facets that HIRAM can offer. I have a few questions myself, but I first would like to give the floor to the people in the room. Would anyone like to ask a question? I don't see anything in the chat, but people can raise their hands if they have any. Silence.
Esther, I
see
have my hand up.
Hilary and Christine, yeah.
Thank you.
Go for it.
Thank you. Thanks for that that really interesting presentation. And I think it's really interesting that you said that you've been working on it for 15 years and it's obviously really well developed. I have maybe a slightly sort of offbeat question, and that is, you mentioned the possibility to add different services, And I'm just wondering whether in a particular environment, whether it would be possible to add traditional practitioners. Now, I know that traditional practitioners obviously are harder to pin down and are not usually registered, well, are rarely registered, but I'm just wondering if you're in a particular outbreak or an emergency, whether there's enough flexibility in HIRAMS to be able to sort of insert a module that says, let's see if we can get a traditional practitioner coverage, we can find out where they are, and could that be put in? I have a couple of other questions, but I'll leave it for now and let others come back with that one. Thank you.
Sure, I'll start with this. Thanks a lot. Well, first, we've never done this, definitely. As you can imagine, in principle, there's no reason why we shouldn't be able to do this. So the way this works is we propose to countries a standard list of services, but that's one of the main aspects of HIRAMS that needs to be discussed and adapted at the country level. So the decision, the way this works ideally is we try to set a coordination mechanism at the country level that encompasses all of the service providers, and the decision is taken within that group, sorry, of which services need to be included in the monitoring. So I think in theory there would be no reason why this wouldn't be possible. In practice, it may actually be fairly difficult. I anticipate. I may have not stressed that too much in the presentation, but essentially the way this works is the information is the responsibility of updating that information lies with those that have a supervisory function over those facilities. So they're generally not people that are sitting within the facilities for all sorts of reasons, easiness, but also to avoid overburdening the facilities themselves. And also because of the nature of the information we're after, it's information that is better known, a level higher up, basically from the facility. And so in the case of traditional practitioners, I'd be wondering, who sort of, who would be doing the reporting, how could that monitoring be in place? There would be practical questions then to be cleared, I guess, but there's no limitation per se. We've started mapping individuals, if you like, in a way, with work on community health workers in Mali recently, as I was showing on one of the slides. So I guess that's a feasibility, but that's a possibility, but feasibility to be looked at.
Yeah, I can certainly understand that, it's not a question one can just say yes or no to, and it would depend a bit, it would depend a lot on the context, but given the traditional health workers in many outbreaks, at least, we'll see so many cases. Actually having a way to feed it in as a service, even if it's then not long-term updated, because obviously people will move and change, and as you say, that's quite a heavy workload to, but sort of for a time-specific area. Anyway, it's just a thought. I think if there are other hands up, I can come back later. But
yeah, there are actually other hands up, and there's also a question in the chat. But one thing, because it links up to what Hillary was asking, Samuel, in terms of the flexibility of the data collection, can you just briefly elaborate on, because you're linking it up, for example, with his data, but the others, is it all new data collection protocols that all these service providers have to commit to, or is it bringing together existing data and that's basically then being updated in the platform? Or sorry, update, yeah.
So it's primary data, basically. So it's forms that are answered by the data contributors themselves. But we're capturing knowledge in a way from people that have a broader knowledge of what's happening under their area of responsibility. So in the case of Mali, we're talking about the district, les médecins, chef de district. So the doctors in charge of overseeing facilities of any given district, because we're asking questions around barriers and aspects like this that have a dimension that lives beyond any single facility, really. So, sorry, I'm trying to get back to your question.
The reason I'm asking this is mainly because if we link it back basically to integrated outbreak analytics, where where we're talking also about the emergencies, right? I'm kind of trying to reflect on in an emergency situation. You're saying one of the critiques or one of the improvement areas is the uptake for modelers and for looking into further using the data for analytics. And I think one thing I can envision and what you're already doing is to quantify, for example, the travel time and these kind of things, which can also inform operations during an outbreak. But how dynamic is your data collection if you're, for example, talking about you're also collecting data on the damage to buildings and the accessibility to health service, which might actually be affected by an outbreak. So how is HERAM basically data then also adapted to a dynamic situation during an outbreak? Or is it mainly then these type of analytics that you've been mentioning you should be thinking of, like travel time and those kind of things, which are a bit more static?
No, and so definitely it's, I think the key there is really the process that allows us to be, when things function well, it's not the case in all of the countries, but that allows us to be very reactive. So first thing, as I was mentioning, it's a dynamic process and there's all sorts of ways that this can be scaled up and down. We can, of course, reduce the number of variables and be much more focused if, you know, we want to be focused on a certain aspect. But the fact that this information is information known at the district level and again doesn't rely on people working in the facilities makes the whole process much lighter and usually easier to update. So we've had an example, unfortunately not well documented, of a deployment during the the cholera outbreak in Yemen in 2017, where we really had daily updates in terms of the cholera treatment centers and also the oral rehydration points that were set up by the partners. So they were sharing their information on a daily basis of new locations that were supported with those services. They were informing through the system when those services were transitioned back to the ministry and so on. So there's really this ability, I think, to follow things, you know, in real time enough. I would say it's never exactly real time, but real time enough to actually inform operations as they unfold. And then maybe back to your first point that I missed on my first answer, if I got you right, is also sort of how does that articulate with the usual health information architecture. And I think we started developing this work under the assumption or the recognition that this particular function of monitoring what's available was very often overlooked. I think it's a piece of information that we've sort of all made the assumption is always available. And that was something I discovered when I came to WHO. And my big surprise that in a lot of the cases that was actually not available. And it's by no means an easy piece of information to put together, let alone a piece of information to keep updated in an emergency setting, or as you were saying, when things keep on changing and sort of external phenomena impact facilities and their functioning. So I think that function basically of the information system has largely been overlooked, and there's different initiatives looking at that since. Obviously, we've made the choice to develop a central service around this because of the nature of the data, because of different aspects, but some of those are the fact that this data is not sensitive in essence, means by having a central services we benefit from all of the economies of scale I was mentioning earlier, from speed in terms of implementation, but also some more leverage to maintain standards, which was something that was also important to us, making sure that the approach would remain as standard as possible and that we would not end up reinventing the wheel. As you surely know, in emergencies, very often we tend to just take off a blank page and start writing things back again. So we had all of those things in mind on how we could maybe tackle that problem. And that's sort of, if you like, in a way, there's also some sort of a strategy behind this. So there are other attempts at tackling this, but I think, and so once that particular function is covered, the connection to the rest of the system is not really an issue in a way. I mean, this is, as I was mentioning, potentially providing the master facility list, on top of which other services can then be plugged or this data can basically be channeled through other systems and reused as required.
Yeah, because I think that maybe a logic point from what you're mentioning is the question from Evelyn. So I saw Christine had a similar question to what I had, but I will give the floor to Christine after if she feels that she has something more to add. But Evelyn is asking, because a part of this is then, as you were saying, right, linking it up to existing data, but part of it is also primary data. So how do you keep the contributors motivated to continue updating? It seems quite labor intensive and data mainly used by decision maker on a higher than district level, especially in context of a protracted crisis.
Yes, so it does depend a lot on the context. Obviously, the most acute the crisis, sometimes the most leverage we get in updating, and indeed, sometimes in the protracted crisis, is a little bit more difficult. The aim for us is that updates happen whenever the situation significantly changes. That's a bit vague, maybe, but really is to avoid having those those cycles of updates. That said, and for the problem you're highlighting here, Evelyn, that's the kind of approach we're taking in those contexts. We're trying to have at least a minimal update every month or every quarter, depending on the context. The way to incentivize these are the usual ones, I would say, trying to make sure the data is looked at and discussed at those different levels, including at the district level. There's sometimes also questions for financial incentives and so on, although that's clearly not a preferred approach for us. I think in terms of how labor intensive this is, we've actually made massive progress on that front thanks to the platform. So a lot of most of the effort, I would say, happens when establishing the baseline. Then updates is really just about changing those few variables that have changed at any given point in time. So there's no need to constantly re-enter the data. So the actual maintenance of the data, beyond the fact that people need to remain in the loop and motivated, is not that intensive once the baseline has been established.
Christine, did you want to add something around the earthquake in Syria and Turkey, or?
No, and since we have a little time, I just want to thank Samuel. It's very interesting, and that's data we are always looking for, obviously. But yes, I mean, hey, Samuel, I'm Christine Dubois. I work at CDC. I'm actually part of the Global Rapid Response team there, and that's the questions have been covered. I think it's basically the adaptability and the flexibility of your system during emergencies. And of course, I'm especially thinking about what's happening in Syria and Turkey, but I think you have covered that, so you don't need to repeat yourself. I just wanted to thank you for the presentation.
Mm-hmm. Nadine.
Hi, thank you. Yeah, I was just wondering whether whether at all, or to what extent, the system is built into existing accountability systems in the country where it's being rolled out. Because I was wondering if, so you said that the data reporter will not sit in the facilities, they will be higher level. So that to me suggests that they will be responsible for ensuring that in their area, the health facilities are working well. So probably it'll be a district health commissioner or somebody of that kind of level. Now, in my experience, these kinds of people have an interest in portraying their facilities in the best light possible, while actually when you go to the facility, often you find that, you know, the number of doctors or nurses available is actually not reflected in reality. So how does this get accounted for? And also, you know, is there a possibility that the data could be used to not only bring accountability down to the level of the health facility, but maybe also up to the government and say, look, here we can clearly see in our data that the level of service delivery that you're promising us is not being done. So please, we need more resources on this. So I'm just wondering how you deal with these kinds of issues.
Thanks. Yeah, that's a really good point, and that's been a worry from whenever we started this work. The fact that we would basically entrust the service providers themselves to reflect on their activities. Questions were also raised around same for partners during emergencies, potentially over-reporting on their activities and so on. We don't have a lot of ways to actually tackle this. The first comment is, if we want to be exhaustive, there's really no other way for us collectively to build that picture. I think that was a point that we had to recognize to start with not working on samples, and nobody out there has the capacity to run across the entire country to regularly update this information. So we worked around that. And I think first from experience, we found basically what we're trying to do. I mean, the first element, the most important one, but that requires time, is what we call peer-to-peer verification and validation. Is the fact that any actor that contributes to this process can see the data of all of the other actors, builds some sort of an accountability across the sector to start with. And we've had lots of cases when discussing results in meetings of partners questioning results that we were presenting in areas that they knew because they were also operating in those areas, or because they had been running assessments regularly. And so really an idea for us is to try and put as much transparency as possible in the process, in terms of what is the data that has been reported on the one hand, but also who has been reporting it. Because we know that, again, I mentioned that it's an important aspect of the platform itself. We know who has been attributed which role and who is in charge of which data set. So that basically the idea is, in the longer run, that those discussions that we would see happening in meetings can slowly start taking place through the platform in a more transparent and also a way that can be auditable to a certain point, if you like. So it's really, for us, the key is really sort of this peer-to-peer, building a community around this, where the temptation of potentially misreporting is no longer valid. On top of this, we've had cases where we've also been running validation on the ground as WHO. It was the case in Afghanistan with the polio program, but also sometimes partners. So there will be also other ways potentially to complement this when there should be doubt. So very often, doubts from say the broader community, but those are much less efficient. Again, in very dynamic situations, by the time we go out and verify, sometimes the delta we measure, could be misreporting, or could simply be the situation that has evolved. So again, doing everything we can so that the transparency and sort of peer-to-peer pressure does the work in the longer run on that front.
Thank you very much. Thanks.
So then Simone has a question actually in the chat. I think by now you've mentioned the example of Mali, right? In your talk around malaria. And then you, during the answering, you mentioned one example from cholera, but Simone is asking, can you give country-specific examples of how this works in a country and how it's been used in decision-making? And if I may add to that, not want to steal the show, but if I may add to that, an example where it's been triangulated perhaps with other types of data as well, like, for example, case incidence data or data from healthcare worker surveys or other contextual data. Do you have a few examples that reflect a bit, that give a bit of an illustration?
Yes, I actually thought when I learned earlier this morning that we had both presentation slots, I thought I should put in some slides, but I haven't. But one example on this maybe is a recent deployment of the approach in Afghanistan. So essentially, when the situation started becoming a little bit complex, we worked, so the particular example of Afghanistan, and I'll call in colleagues here if they want to intervene, especially Caroline has been following this very closely. We've mostly worked through the cluster in that case, because most of the service delivery in Afghanistan, for those of you that have worked in that context, as those of you will know, is outsourced to partners. So we've worked through those partners, and we've been able to deploy and sort of get a baseline established on over 3,000 health facilities in about a month and a half, in a context that was fairly difficult, and issue the first report. how was the data used? It's always very difficult to judge, not being on the ground. The results of the external evaluation that was run in 6 countries were very positive on that line. A lot of people at the country level have been questioned on whether they know enough of the information and in which sort of instance they've been using it. But in the case of Afghanistan, for example, there's been work done on the modeling under the label of underserved areas. So trying to identify those areas that are too remote from facilities and certain specific services. And we're hearing this particular work is getting a lot of traction locally from all of the actors. There's really a lot of demand around the data. And it's apparently also used very much for planning or simply for sort of justifying proposals that NGOs are putting in terms of new services they want to deploy to the ground. But that would definitely need to be assessed further. And as I was mentioning also through the presentation, it's also been identified as an area that we need to improve on really sort of all of the uptake of information. As I was saying, it's been sort of a fairly heavy lift getting to a point where we feel confident we can get the data, but we surely still have a lot to do in making it much more digestible and usable for decision makers.
Yeah. Ruby, I believe you had a question as well.
Yeah, sorry, I can't seem to put my hand up. Yeah, I was just wondering about coverage of the data. I had a quick look on the website earlier, and it looks like it can be quite limited and perhaps not in our traditional emergency areas like the Kivus.
Thanks. I just saw, sorry, if you allow, Ruby, I saw Caroline, you had your hand up. Maybe you want to add something on Afghanistan or another country because you've been following those more closely. Just briefly give you the ground, then I'll come back to your question, Ruby.
I just wanted to add, speaking about Afghanistan and like the way that the data has been used, one of the more innovative additional uses they've had was also linking it to the distribution of medical kits. So they have linked it to track the way they're distributing any kind of medical kits to different partners, so that this is like linked to the updates in HIRAMS as a way to also see how this is then improving the situation in the different districts. So maybe just as another way of how it has been used. Thanks.
Thanks for adding. And so back to your question, you're right. I think sort of the entry point to date for us has not been outbreaks. It's mostly been protracted emergencies, I would say, and in some cases, sort of more of the sudden onset crisis. So that's why I think you would not necessarily find a lot of overlap right now in terms of what we cover and the areas you're usually working in. But that's something we've been considering and something we'd basically like to start looking into, you know, how useful that kind of a work could be in an outbreak response, and you know, would there be scope and space for that to actually take place and support the ongoing response. And same again in terms of coverage, you'll see that from the site as well, but it's obviously not always necessarily the entire country, depending on the requests we're getting and the situation on the ground.
Christine, you had your hand up for a while. I wasn't quite sure it was a new one, so go ahead.
Sorry, I am on my phone. My internet crashed yesterday. No, it was an old one. I thought I had taken it down. Sorry about that.
Oh, okay. Yeah.
Come.
Any other questions? No further questions? Is there anything, Samuel, you would like to say or finish off with?
No, I'm good. Thanks. Just want to thank you for the invitation and thank everyone for joining the call.
No, thank you so much for this outline. I think it's a super interesting source for all of us here on the call in different types of analysis, right? And yeah, if there are no further questions, I'd like to leave it here.
Can I just quickly update about what the next session will be in 2 weeks' time, which will be integrated outbreak analytics and One Health. So please join us for that.
Bye, everyone.
Thanks a lot.